Hello, professors.
Hello there.
Good evening or
Okay.
morning.
Good morning. Good evening.
Good morning to me. So good evening to you. So how are you?
Great. How are you?
Doing great. Thank you. So time it goes to 8 p.m. So let's start.
Okay.
Okay. Uh, Good evening and good afternoon, good morning to you, depending on where you are. So thank you for joining us today, the 17th global webinar of Masonic Netherlands College, broadcasted from China to the world. So my name is Alex from Masonic Medical. So today we are very pleased to have Professor Arun Kalava and Professor Mark Leonard as our webinar speaker and moderator. The webinar topic is lower extremity nerve blocks, refresher. It will take about 1 hour to 1.5 hours. So firstly, let me walk you through all the details of today's webinar. So at the beginning, I will give an introduction to Professor Mark Leonard, and then Mark Leonard will give a brief introduction to Professor Arun Kalava. Then Professor Kalava will start his speech for about 1 hour. So during the webinar time, all the audiences can raise their questions, and Professor Leonard and Professor Kalava will help give answers after the lecture. Now let me share my screen and give Professor Leonard an introduction. Professor Mark Leonard is one of the only two mid-level licensed anesthesia providers, both in the United Kingdom and USA. He's currently the assistant professor at Nova Southeastern University for the anesthesiology assistant program in Tampa. He's now a certified assistant anesthesiology assistant at Team House. He's also assistant director for ultrasound expert. Ultrasound expert organizes many group courses covering the adult and pediatric regional anesthesias. It is an educational resources for the ultrasound guidance in regional anesthesias. So anyone who have interest to knowing more details, please visit their official website. So Professor Leonard graduated from University of Birmingham, United Kingdom, for physician's assistant in anesthesia program. Now it's called anesthesia assistant AA. After graduation, Professor Leonard practiced as a PA at the Queen Elizabeth Hospital, Birmingham. It is a 44-hour university teaching hospital, alongside over 100 attending anesthesiologists and close to 100 resident anesthesiologists. Professor Leonard has a long history of teaching physicians, PAs, AAs, and many other OR-related professions, and sharing the knowledge he has gained from his clinical experiences. So this is some brief introduction to Professor Leonard. So now let's welcome Professor Leonard to give a brief introduction to Professor Kalava. Please, Professor Leonard, thank you.
Thank you very much, Alex, for that wonderful introduction. Thank you, everybody, for joining us this evening. I will give you an introduction to our key speaker tonight, Professor Arun Kalava. Dr. Kalava is an anesthesiologist with fellowship training in regional anesthesia and acute pain from Mayo Clinic. He's board certified by the American Board of Anesthesiology and the European Society of Regional Anesthesia and Pain Therapy. He has a faculty appointment as Assistant Professor of Anesthesiology at the University of Central Florida, and he currently practices acute pain and chronic pain medicine right here in Tampa, Florida, where we both are this evening. He's an avid researcher, and he's a published author of nearly 20 scientific articles in regional anesthesia and pain medicine. He's been offering clinical ultrasound education via his ultrasound experts company to hundreds of anesthesiologists, anesthetists, pain physicians, and emergency physicians for many years, both here in Tampa and across the United States. So without further ado, I will let Dr. Kalava take you on to tonight's topic. Thank you.
Good evening, Alex, and good evening, Mark. Thank you for the introduction. Good evening to people in the United States. Good morning to people in Asia, China, and maybe good afternoon somewhere else. It's a pleasure to be talking about this topic today. The topic is lower extremity nerve blocks. Obviously, we'll be talking about ultrasound-guided lower extremity nerve blocks. Just a refresher. So I'll dive right in. The agenda for the talk would be to talk about the commonly performed ultrasound-guided lower extremity blocks in clinical practice today. We'll talk about different blocks, what are the indications, in the sense, surgical indications for each particular block. We'll also talk about the normal anatomy. We'll talk about the sono anatomy, that anatomy that we see when we put the ultrasound probe on for these different nerve blocks. We'll also talk about a little bit of aberrations that we might see in these nerve blocks in certain patients. We'll also be discussing the in-plane and out-of-plane approaches to these nerve blocks, as there's two ways of doing these nerve blocks. At the end of this session, we do have a Q&A, so if you have any questions, please send the panelists questions that you might have that might come up during the presentation, or if you already have a question that you want to be answered. We'll be happy to answer at the end to the best of our abilities. So what blocks are we talking about today? So the main blocks we're focusing on today is femoral nerve block, fascia iliaca block, the PENG block, IPACK block. We're talking about the sciatic nerve block in the popliteal space. We won't be talking about the anterior approach or the subgluteal today because they're a little more advanced and uncommonly performed. We'll also talk about the saphenous, or more commonly called adductor canal block. We'll talk about the ankle block a little bit. So the first block is obviously the femoral nerve block. We're starting from proximal to, we're gonna go distal as we talk about these nerve blocks. Good indications for femoral nerve blocks are total knee replacements, total hip arthroplasty replacements, any femur fractures, patellar fractures, anterior cruciate ligament repair. It's the ACL repair if somebody's doing arthroscopic or open. A very good indication, I believe, still stands is somebody who's having an above knee amputation. Again, if it's an above knee amputation, you have to combine the femoral nerve block with the sciatic nerve block. So looking at the anatomy, the femoral nerve comes from the lumbar plexus. The lumbar plexus is shown in the screen as you see, and the femoral nerve it comes from the posterior divisions, not the anterior divisions, posterior divisions of lumbar 2, 3, and 4. So it's L2, 3, and 4 posterior divisions, which gives the femoral nerve. The anterior divisions actually form the obturator nerve. So be mindful if there is a question about it, it's the posterior division, not the anterior division. Moving on. So this is a picture, a very good picture of how the femoral nerve is placed next to the vasculature. You see the blue is the vein, the femoral vein, the artery is in red, and the nerve is in yellow. So they're placed again, right next to each other in a vein, artery, nerve fashion. So the nerve is most lateral of all three structures. So when we're looking at anatomy or the sono anatomy, I think the best thing to find is the femoral artery first, and then try to see what's lateral to it. that's one way of finding the nerve more reliably. So the sonoanatomy picture, as you can see, depicts the same thing that we just saw in anatomy. The femoral artery, the medial aspect of femoral artery is the femoral vein. We see the spindle-shaped femoral nerve, lateral. So this is the lateral aspect and the medial aspect of the screen that you will see in an ultrasound. There's a couple of things that you have to identify: fascia lata and then the fascia iliaca. This is the iliacus muscle, which is a very big muscle which lies lateral to the femoral nerve. So fascia on top is fascia iliaca, so the nerve actually is under the fascia iliaca. Moving ahead. So aberrations, as we talked about, there's normal sonoanatomy, and sometimes you will see something not so normal. And this is one of my patients which we were scanning, and we found this metallic circular thing in the artery, which is actually a vascular stent because the patient had peripheral vascular disease, and they ended up getting a stent to improve their vascular supply in the lower extremity. In this case, the ultrasound picture is not great because, one, the patient's about 90 years old. They have this vascular stent. Even the nerve is not very well delineated. So in those cases, it's not a bad idea to actually use a nerve stimulator to identify whether, hey, is this the nerve or something else is the nerve? So usually I don't use any nerve stimulators, but there is a questionable nerve, then there's nothing wrong in actually identifying with the nerve stimulator. I have a few videos I'll be playing throughout this presentation. So as we do these, we'll be talking about in-plane techniques and out-of-plane techniques. This is, again, the anatomy is what we're going to look at: the iliacus, fascia iliaca, the vein, artery, and nerve that you can see. I'm going to play the video, and we'll see an in-plane technique for a femoral nerve block. Oh, sorry. So you see the artery pulsating. The goal is to get to the lateral aspect of this femoral nerve and try to inject the medicine, a local anesthetic, around in the proximity, not into the nerve, but perineurally. So once you inject, we start seeing the medicine surrounding the nerve, which is a spindle-shaped nerve. The main part of this nerve is the posterior division of the lateral, which is the lateral part of the nerve, because the posterior division of the femoral nerve actually supplies the knee joint. So if you're targeting the knee, I strongly recommend you trying to be on the lateral aspect of the nerve, not the anterior division, which is more supplies the quads and the anterior aspect of the thigh. So now at the end of this scan, you will see a good spread of local anesthetic around the nerve. These things are moved, obviously, with the movement of the probe, artery and vein. That will be one picture. So there's another picture, another video I would like to play. This is an artery vein, femoral artery, femoral vein, iliacus muscle. The fascia is not very well defined here. The femoral nerve is not very well visualized. So I'm going to play this to see how this nerve block's done in an in-plane technique. The needle is coming now in plane. You're following the tip slowly. So trying to go to lateral to the artery, stay lateral to the artery. So start injecting, and you start seeing this hyperechoic structure posterior to the, if you see, posterior to the needle actually. So the nerve actually appeared now rather than before. It's the tilt of the probe, or it could be a multiple of factors. So I actually, at the end, came back and injected around the nerve because this is not a good spread around. I'm just showing you what could be happening when you're doing a nerve block. Make sure the nerve is actually surrounded by local anesthetic. This is, though the video stopped here, we came back and then injected in this area. So this nerve is bathed in local anesthetic. So your nerve block is successful rather than being a failure. The next block we'll move on is fascia iliaca block. Now, this is also called a 3-in-1 block. We're looking at the femoral, obturator, and lateral femoral cutaneous nerves being simultaneously blocked. And the most common indications that I've seen in different practices is either a hip fracture or a total hip arthroplasty, which is THA. One thing you have to be mindful is that the local anesthetic concentration for this particular block, unlike many other blocks, is a dilute solution of ropivacaine or bupivacaine. And you do need a large volume, as that will hopefully track up the iliopsoas and iliopsoas compartment to get to the lumbar plexus. There's two approaches that have been described, suprainguinal, above the inguinal ligament, and there's infrainguinal approach, which is below the inguinal ligament. So this is the suprainguinal approach. The sonar anatomy pertinent to that is you'll be looking for the internal oblique and the iliacus muscle itself right on top of the ilium. Now, we start off at the anterior superior iliac spine with a high frequency probe facing the umbilicus, and we're going to scan medially and inferiorly until we find the anterior inferior iliac spine, wherein we find the internal oblique, the iliacus muscle, and an in-plane technique coming from below to above should place the needle right under the fascia, and after aspiration and making sure there's no aspiration of heme, you would inject about anywhere from 30 to 60 cc because it is a volume block and it depends heavily on the volume that injected. So there was a study out in 2019 by Vermeulen K. Excuse me. They studied both suprainguinal and infrainguinal approaches to fascia iliaca block and found that the suprainguinal fascia iliaca block seemed to be giving better results when it comes to sensory block versus an infrainguinal approach. So how is the infrainguinal approach done? It's very similar to the femoral nerve block, just scanning a little more lateral and depositing the medicine just underneath the fascia, as we showed in the previous slides. If I can go back quickly to show you where exactly you'll be injecting. So this is the fascia iliaca, and we'll be injecting right in this area. This is the infrainguinal approach. You'll be going much more lateral and injecting. I'm going to go forward again to where we were. So if I have to do a fascia iliaca block, I would choose a suprainguinal approach versus infrainguinal approach. So this is the suprainguinal approach. The one I showed you is the infrainguinal approach. It is a reliable block, but it is not the go-to block. Again, for any hip surgeries, lumbar plexus is still considered gold standard. The next block we'll talk about is the new pericapsular nerve group block, also called the PENG block. Now, PENG is a block described by William PENG. He's a Canadian anesthesiologist, Philip PENG, who was a Canadian anesthesiologist in 2018. It has rapidly grown. A lot of providers have started using. The reason why they started using was, one, there is no motor weakness, unlike a femoral nerve block or a lumbar plexus block. And there's had been a lot of data, just case series and case reports on patients with hip fractures, total hip arthroplasty, and hip arthroscopy. The volume recommended as of now is about 20 ml of 0.5% ropivacaine. There was one report of some quadriceps weakness following a PENG block because they put too much of volume, which kind of engulfed and covered the femoral nerve. So be careful on the amount of volume you use and where your needle tip is. So looking at anatomy, these are pictures from the actual description of this nerve block from Dr. Peng. We're targeting the articular branches, which is articular is the joint related branches of the femoral nerve and the accessory obturator nerve, which can be consistently found between the anterior inferior iliac spine and the iliopubic eminence. In this picture, if you look at the hip joint, there's green colored articular branches of the femoral nerve, and this is the blue color. Blue is accessory obturator nerve, the articular branches. So we're just depositing local anesthetic to provide analgesia of the hip joint by targeting the articular branches of the hip joint. So the actual sonoanatomy is this way. So we usually use a low frequency probe, unlike most blocks in lower extremity where we use a high frequency probe. The low frequency probe is placed just in the inguinal crease, and you can either find the hip joint first and scan proximally. As you see these arrows, you're going to start finding the hip joint with the round circular femoral head, then scan a little more proximal to find the psoas tendon, the femoral artery, the iliopubic eminence, and the anterior inferior iliac spine. This is the medial aspect of it. This is the lateral aspect of it. The goal is to deposit this medicine posterior to the psoas tendon. So the needle will come from lateral to medial, targeting the posterior aspect of the psoas tendon, right above the pelvic bone here, which is the IPE and the anterior inferior iliac spine. So to show you how it actually is performed, I'm going to show you a video of a block I recently performed on one of my patients. In this video, this is the medial aspect of it. This is the lateral aspect of it. You're looking at the femoral artery as I play. You see the psoas tendon. The goal is to come in plane from medial to lateral to medial, and place the needle posterior to the psoas tendon, where we'll be injecting about 20 cc of local anesthetic. So let's play and see. Femoral artery. The needle is coming in plane. As you can see the tip. So the injector is going posterior to the psoas tendon. So 20 cc of that, make sure you don't give too much of medicine, because if you give, the nerve is right in this area, so that will get bathed, and now you have quadriceps weakness or motor power weakness. A good depiction of the PENG block in plane approach. Now, there is something called IPACK. Now, what does IPACK stand for? IPACK stands for interspace between the popliteal artery and the capsule of the posterior knee. Now, if you look at this image, these are the popliteal vessels, the artery and the vein. You see the knee joint capsule. Most likely, this is the femur at this point, or the femoral condyles. The goal is to deposit the medicine between the artery and the capsule of the posterior part of the knee. The indication so far is any posterior knee, most commonly following a knee replacement. Let's say somebody has a knee replacement and they have anterior pain covered by saphenous nerve or femoral nerve. And if they complain of posterior knee pain, this is a very good block to perform, because it only gets the articular branches of the sciatic and the obturated nerve. So there's no motor weakness down below the knee. So if you look at these pictures, there's a couple of approaches. One is a distal technique, wherein the patient is prone and you scan and find the popliteal vessels and inject between, this is the condyle, the femoral condyles, and then you inject between the vessels and the bone or the posterior capsule. Similarly this way, or you can do a saphenous nerve block and bring your probe down a little more medial and inject between the femur and the popliteal vessels. It can be done in a similar fashion as I would do a popliteal sciatic as well, which we will go over in a few minutes. So a good block for somebody who's having a knee replacement and has posterior knee pain without causing any lower extremity weakness, in the sense the leg being weak from sciatic nerve involvement. So this is a picture of a recent article from 2019, which actually shows how the local anesthetic, in this case, the dye is being depicted as to how the local anesthetic spreads in the posterior aspect when somebody does an IPACK. Both lateral, posterior, and medial spreads are being depicted in these pictures. Now, there's two IPACKs that have been described. There is really not much a difference between these two. It just depends where you have to place the medicine. IPACK 1 and IPACK 2. So my preference is trying to stay as close as possible to the condyles, because a little further higher up, the sciatic nerve is in this place. So I don't want my medicine affecting the sciatic nerve, and the patient has leg weakness or foot weakness, which avoids him or her in ambulating or walking. So very important to try to be as distal as possible than being as proximal as possible. Sciatic nerve, it's one of the most common nerve blocks that are performed in the lower extremity. Total hip arthroplasty, total hip arthroplasty is an indication if you're doing higher up. Total knee replacement is an indication if you're doing subgluteal or a Labart approach to sciatic nerve. But if you're doing a popliteal approach, any surgery below the knee is a very good block to do. The best block probably you can provide this for is a patient who's undergoing a below knee amputation. Now the optimal volume is just about 20 cc. I don't think you need 30, but some providers do use 30 cc if they have enough to play around. So if you put in 20 cc, it's plenty. Now, if you look at the anatomy, the sciatic nerve comes from the lumbosacral plexus. Now, when I say lumbosacral, it's L lumbar 4, lumbar 5, sacral 1, sacral 2, and sacral 3. So it's L4, 5, S1, 2, 3. Now, if you look at the thickness, sciatic nerve is the thickest nerve in the body. It measures about 2 centimeters and traverses in the posterior aspect of your lower limb. But today we'll be just focusing on how to do a popliteal sciatic. If you look at this picture, the patient's lateral decubitus, you're using a high frequency probe to do this nerve block. The best position is lateral decubitus. You can do prone, you can do supine, but there is a lot of consensus that the lateral decubitus is probably the best position for the provider and also the patient. So if you look at this sonoanatomy, we're looking at popliteal vessels, both the artery and the vein. We're looking at the nerve dividing into tibial component and common peroneal component. This is the distal sciatic nerve where it divides. A more magnified version of the sciatic nerve is this. There is the thicker, bigger sciatic component, tibial component, and common peroneal component. Two approaches to it: out of plane, where you can come between these two nerves, or in plane, wherein you come lateral to medial, with the possibility of, scraping past the common peroneal. So I'll go over both approaches so you can decide on your own what works best for you. For me, the out of plane works best for me because I do a lot of single shot injections. When it is a catheter, I always try to do in plane so I can place more of a catheter in the patient's leg. So this is the position of the patient. If you're doing an out of plane approach, you'll see a video that I'm going to play. This is the common peroneal tibial component artery. My goal is to get the needle straight down from the skin between these two divisions of the sciatic nerve. The needle has now entered between the two components. We're trying to inject, so see the spread of the local anesthetic around the nerves. It's very uncommon to see providers doing this, so I'm trying to show them it's okay to do an out of plane and it's safe to do, and there's no neural injury that you can think of as long as you know the needle is going between these two components. That was one example. So I'll show you another example, a different patient. You have a tibial component, common peroneal. We're trying not to touch any of the nerves because you don't want to be intraneural. You have to be perineural injections. Same thing, we're looking at the endpoint is seeing good local anesthetic spread around both the components of the sciatic nerve. Another example of the same approach of out of plane. Common peroneal tibial components. So I'm trying to get in between, start injecting, see where the medicine goes. Is it bathing both? Yes and no. So one thing I've found is approaching this way, it seems to be extremely easy, less time consuming. And that's why I use that as most of my single shot blocks. Now we'll also look into popliteal sciatic in plane approach. So this is the artery. We're looking at the nerve here, the tibial component. Common peroneal is right in here. The needle has come in, the shaft of the needle, so the tip of the needle somewhere here. We're trying to go in between those two components, making sure we're not trying to touch any of the nerves or go intraneural. Now, my goal is to make sure I see local anesthetic spreading around these two nerves, the distal divisions of the sciatic nerve, tibial and common peroneal. The artery is visualized here. The goal is obviously to see the medicine around these two. So in-planar technique is a little more challenging to a lot of providers, but it is the best technique to do when you're placing a catheter. Now, how does a catheter look like when we do a sciatic nerve catheter? It's a good modality of analgesia or pain relief in patients who have major ankle surgery that includes ankle fracture repair. It includes ankle replacements. There is quite a few ankle replacements that are being done in the United States. I'm not sure. I'm sure there are other countries who do ankle replacements. This is one of my patients. We placed a sciatic nerve catheter in plane for 7 days following an ankle replacement. If you look at, this is the lateral aspect, so my needle coming from lateral to medial. This is the biceps femoris, and I'm actually traversing the biceps femoris with the catheter. The nerve is here. I'll play the video, and we're testing the nerve catheter at this point to see, making sure before I tape it that the catheter is actually bathing this nerve, because they'll be going home with this nerve catheter. So these are the train tracks that I call. We're trying to aspirate and trying to inject now. Look at this area where the medicine is trying to spread. At the end of the picture, you actually see the nerve really clear. So wait until the end. So you still see medicine being spread, and we're waiting for the good nerve picture at the end. So if you see, this is the nerve. So we ended up with the nerve. This is the area where the local anesthetic is spreading. So this tells me that this is a great catheter that I can leave with full confidence that the patients will have analgesia and anesthesia if required for a very long duration. Catheters are usually left for 7 days, and not more than that, because there's increased chance of infection at that point. So this patient is doing well. This was a week ago that I placed. Doing really well with the catheter. We do have some issues now and then with the medicine running out, but we keep refilling those local anesthetic for the patient. Last but not the least, there was a study out in 2017 to compare an in-plane and out-of-plane technique of distal sciatic nerve block or the popliteal sciatic nerve block. This was in Germany, Geiser et al. What they said was, when you're doing a distal sciatic or sciatic nerve block at the popliteal crease, an out-of-plane technique between the tibial and common fibular nerve can be done really fast, effective, and safe, because you're not touching anything, and it's super easy and fast. So something to keep in mind, that there is evidence behind it. It's just not me telling. This is an alternative approach if you or somebody has difficulty in doing the popliteal sciatic. The next block we talk about is the saphenous or adductor canal block. Good indications and robust evidence for this is total knee replacement. It's good for ankle fractures or ankle replacements when we have to cover the medial aspect of the ankle. It also can be used for ACL repair. The typical volumes anywhere from 10 to 15. It's a saphenous nerve is a terminal sensory branch of the femoral nerve. So we don't require a lot of volume, and also it is motor sparing. So the surgeons like it as it doesn't cause any quadriceps weakness, which femoral nerve does cause. So it helps ambulating pretty early when somebody has a total knee replacement or total ankle replacement where there's no weakness of the quadriceps muscle. If you look at the anatomy, you see the saphenous vein and artery and the nerve in the adductor canal, with the medial aspect of this boundary of this adductor canal being bounded by the adductor muscle groups and the lateral by the vastus medialis. So anatomy wise, you're looking at skin subcutaneous tissue, a boat-shaped muscle called sartorius. You're looking at a vastus medialis, which is the lateral aspect of an adductor muscles, which are the medial aspect. This is a superficial femoral artery. You see the nerve lateral to it. There's quite a bit of variability as to where the nerve could be found in the adductor canal. So recommendation to stay under the fascia of the sartorius within the canal and, inject about 10 to 15 cc of local anesthetic, usually high concentration, so it gives you a longer relief. Now, routinely we place catheters for knee replacements in this place. You can place, as I said, for ankle replacement, I'll place a catheter as well. Just to play a video of how an out-of-plane saphenous nerve block appears. So here's the vastus medialis, femoral artery. I will start superficial, try to get to the area where I need to. So you see the tissue displacement when you use an out-of-plane technique. The goal is to see the local anesthetic spreading in the area, which you are able to see. So it seems very fast. It's very safe. There's no critical structures in the area. Finding the needle tip is not required, as I can see the displacement of the tissue in this area to go to the saphenous nerve. So let's play it again. Goal is to see local anesthetic spread along the lateral aspect, preferably, or within the canal. So I'll do an in-plane approach as well. A different patient, sartorius, vastus medialis, adductor muscle groups, femoral artery, superficial femoral artery here. Most likely the nerve is in this area. We want to come posterior to the sartorius and inject in the area or in the adductor canal. So let's play the video here. You see the artery pulsating. I'm using an 18 gauge nerve catheter needle. So this is a thicker needle, so you're able to see it better. The thicker the needle, the better the visualization, because the ultrasound beam hits the needle and gives us the better resolution of the needle and the needle tip. So I'm slowly piercing the posterior sheath of the sartorius, trying to be lateral to the artery. There seems to be some resistance in that area, so I'm overshooting and then pulling back the needle and then confirming the tip of the needle placement and the medication spread around the nerve. So you actually can see the nerve briefly as I inject, as it's floating in the local anesthetic. Let's play it again. In-plane approach to your saphenous nerve block or adductor canal block. Finding the needle, looking at the tip, make sure you're going slow. Identifying the target, which is lateral aspect of the artery. Injecting in the area where the adductor canal resides anatomically. Okay, so we'll move to the next slide. Sorry. So after I did the injection of local anesthetic and confirmed the position of the needle, I placed a catheter in this particular patient. So our goal is to look at this area where the nerve is. This is the catheter. We're going to aspirate first, which will show some vibration in the catheter. There's the vibration. Then you see local anesthetic spreading in the area lateral and in the adductor canal. So that's why we confirm and say, okay, well, I visualized, I confirmed that this actually is in the right place where I want it to be before I tape and send the patient home or send the patient to the ward, the surgical ward where they recover. So you're seeing the spread around this area. There we go. We move to the next one. The last block we'll be talking today is the ankle block. Now, Ankle block can be performed both blind. It can be performed ultrasound. Why would I choose an ultrasound guided ankle block? Well, there's a couple of reasons why you would choose an ankle block using an ultrasound. One is you can use lower volumes. Two, you can be very precise. You can look at the nerves and deposit the medicine. And three, you can be certain that this block would work because you have you guided your needle under ultrasound to find these nerves and deposit the right amount of medicine and see the spread around these nerves. The indications obviously are any toe amputation. Also, you have to figure out what toe is being amputated and then what nerve supplies that particular toe before you decide on doing what particular nerve. Sometimes you might have to block all 5 nerves. Sometimes you only have to block 1 nerve depending on where the surgery is being done or a procedure is being done in the emergency room. I typically use about 20 ml of 1% or 0.5% ropivacaine. That usually suffices for the entire ankle block, all nerves. Let's say it's a single nerve that I have to block for a minor surgery in that particular area. Then I would just use 5 to 7 cc of that particular local anesthetic to bathe the nerve. If you look at the anatomy, there's 5 nerves, as we all know. Sural nerve, which is a sensory nerve, supplies the lateral aspect of your foot. So all this is sural nerve. So if somebody's operating in this area, I want to make sure I get the sural nerve. Let's say somebody's operating in this area, then I want to make sure I get sural and the posterior tibial, which is the tibial nerve. If they're operating on the heel, I want to make sure I get the calcaneal branch of the tibial. So I'll just do a posterior tibial. So if you look at this yellow, this is the calcaneal branch of the tibial nerve. So saphenous, anything medial is all saphenous. Anything superficial on the dorsal aspect of the foot is superficial peroneal. The deep peroneal only supplies the web space between the first and second toe. So if somebody's working the first toe and amputating it, I need to make sure I get the deep peroneal. If they're working on the third toe, you don't need. You just need the superficial peroneal and maybe the posterior tibial nerve. Having said that, a cross-section of the foot at the ankle level, the leg at the ankle level will show you these nerves which are surrounding the ankle area. Now, if you go posterior and lateral, you have the sural nerve. Superficial peroneal is very superficial. Deep peroneal is between the tibialis anterior tendon and extensus hallucis longus tendon. Saphenous nerve always runs with this great saphenous vein, which is very easy to find. If you have difficulty finding, you can put a tourniquet around the leg and the vein becomes really prominent and you just have to inject the medication around the vessel. Posterior tibial nerve is very close to the posterior tibial artery, which is right between the medial malleolus and the Achilles tendon. So let's look at how the sonar anatomy of these nerves look like. This is the sonar anatomy. We're using a high frequency probe, medial malleolus, so inside of the foot, Achilles tendon, medial malleolus, posterior tibial nerve. You see the venous structures around and the artery. So if I were to play, this will be pulsating. You can either come in plane or out of plane straight down and deposit about 5 to 7 cc of local anesthetic for a very reliable block that covers the entire plantar aspect or the bottom of the foot. Similarly, the web space between first toe and second toe can be covered with the deep peroneal nerve block. The deep peroneal nerve is lateral to the anterior tibial artery. You'll see the pulsating artery, high frequency probe right in the supramalleolar area in front of the leg will show you the artery. You have to deposit the medicine lateral to the artery, hit the bone, come back a millimeter and deposit about 5 to 7 cc of local anesthetic. The sural nerve is easy as well. It's just opposite of what the posterior tibial nerve block would be. You place the probe supramalleolar between the Achilles tendon and this is the Achilles tendon and lateral malleolus. You see a short saphenous vein, the SSV, and the injector is around the nerve, which is at the level of the ankle. You can also block this nerve in the calf. It's very superficial under the gastrosoleus, just above the gastrosoleus under the skin. So local anesthetic should be done in the proximity of the short saphenous vein. The saphenous nerve should be blocked around the great saphenous, as we showed in this slide where the vein and nerve coexist. superficial peroneal nerve can be blocked just by a superficial ring-like infiltration of the skin. That pretty much ends my presentation for today. I will take some questions from Professor Leonard and other delegates who are watching this in China and around the world.
Thank you, Dr. Kalava. Very informative. There's clearly a lot of information to get across there. There were some new blocks in there as well, which are becoming very fashionable and very important at the moment. We've had a few good questions come in now, which I'd like to pose to you. The first question I'd like to ask, and I know you alluded to it during the presentation, was just could you describe the differences between the IPACK 1 and the IPACK 2 block? And when would you use an IPACK 1 over an IPACK 2? What would be your indication for that?
So good question, Leonard. So the difference between 1 and 2 is the location of the injecting. Whether you're injecting just over the femoral condyles or the shaft of the femur. So my preference is to inject just above the condyles because I'm further away from the sciatic nerve, because the last thing I want is to try to control the posterior knee pain to actually numb the sciatic nerve, where now the patient cannot walk because the sciatic nerve has been affected. We're targeting the articular branches of the sciatic and obturator in this IPACK block. So there is not many studies out there comparing IPACK 1 and 2, but it makes logical sense to be sticking to the one close by, close to the femoral condyles.
Okay, thank you. And I prefer an IPACK 2 block for my total knee arthroplasties. I will do an adductor canal and an IPACK 2 block for those patients, and they will be ambulated, mobilizing very quickly and using that knee very soon. So I agree with you. So let's talk about the femoral nerve block now. And could you just describe how you would position your probe for a femoral nerve block? And the various ways that you would utilize, and I think again you alluded to that in the presentation, so the various ways you would block the femoral nerve.
So the femoral nerve block, when we're doing it, it's very superficial. As you know, we can feel the femoral artery if you in the inguinal crease, if you're not sure where to place it. Most patients or individuals have the crease that you can find in the groin crease, and place your high frequency probe, trying to identify the artery first before you identify the nerve. So I would either feel the artery, the femoral artery, and then place the probe, or place the probe in the inguinal crease, and then scan to find the artery by scanning more medial, because the artery is more medial. Then try to tilt the probe to find a crisper image of that nerve, which is lateral to the artery. Now, the approaches, as we talked about, are to in plane or out of plane. You can approach both in plane or out of plane, depending on level of your skill and also the patient anatomy. So if somebody's extremely large, 500 pound or 250 kilo, an in plane might be difficult. So you might want to choose an out of plane technique. So there's two techniques, as I said, an in-plane and out-of-plane technique. Both techniques are acceptable as long as you're not intraneural, and try to stay lateral to the nerve and make sure there's a local anesthetic spread around the nerve.
Okay, thank you. Modern day ultrasounds, we get access to a lot of ultrasound probes nowadays, and you'll find many machines don't just come with the linear probe that we were used to. We get a large selection of probes available now. In relation to a hockey stick probe, for example, what would be your indications for using a hockey stick probe, and some of the reasons you would choose that over a traditional linear or a curve?
Good question, Lem. So I think hockey stick is a very good tool if you're doing a lot of pediatric anesthesia or pediatric regional anesthesia, because we're talking about kids 2 years, 5 years, 6, 10. They're small body frames and nothing's deeper. Most of the things, these blocks and nerves are very superficial. So if I were doing a small kid, I would use a hockey stick in that particular case. Even adults, if they're very skinny, you can probably look into using hockey stick. The other indication is most of the ankle blocks, I think 100% I would say, you can use the hockey stick to find the nerves, because the nerves are very superficial, and it gives a very good image for superficial structures with the hockey stick. So as in pediatrics, the area that we can scan is very minimal. So having a smaller probe will certainly help in a pediatric patient for sure. Adults, I would choose hockey stick if I'm doing an ankle block. Other blocks, not so much, because there is enough area to put a larger high frequency probe versus a very small hockey stick.
I would agree, and I certainly think in the ankle block situation, the hockey stick is a nice compact probe, very high frequency, so we get great visualization of those very small nerves. So the hockey stick is certainly an essential when I'm doing any foot or ankle surgery. So with regards to the sciatic nerve block, what surgeries would you perform a sciatic nerve block? And are there any complications with that sciatic nerve block? Any classic cases you could discuss with us?
Sure. The indications, primary indications, the best indication I always see is a below-knee amputation in combination with a saphenous. The next indication would be an ankle fracture, an open reduction or a closed reduction as such. The third indication would be an ankle replacement, or any other surgery on the foot would be my indication. Now, when it comes to complications, I've seen at least 2 or 3 in the last 2 years of my career wherein patients have common peroneal nerve injury. It seems to be happening either in a patient who had a block with a concomitant use of tourniquet in the thigh. So sometimes it's very difficult to identify whether is it the tourniquet causing the ischemic injury or is it the nerve block per se, because the patient in these circumstances were awake and they did not complain any severe pain or injection. So, and that's probably one of the reasons I usually shy away from doing an in-plane approach, as the common peroneal seems to be coming in needle's way, and it seems to be a little more challenging. And I try to avoid that by going between the tibial common peroneal component for that reason, and also for the ease per se. So 2 of these patients had nerve injuries, mostly the common peroneal. As I said, they had some foot drop. They had, one of them had some symptoms of CRPS. So extremely cautious with this nerve, because it is the thickest nerve in the body. There's a big nerve and you have a smaller needle which can easily penetrate through these nerves and cause damage. And it's probably one of the most commonly seen nerve injury out there that I encounter in my private practice. So extreme cautions when you're doing sciatic nerve blocks, because it's such a big nerve. The chances of the needle getting into the nerve are higher, and intraneural injections seem to be a little higher than other areas of the nerve blocks.
Okay, thank you. What would be your nerve block of choice for an ACL repair, an anterior cruciate ligament repair?
So, good question, Mark. So ACL is anterior cruciate ligament, and it can be done either an open repair or a laparoscopic, a knee scope, arthroscopic repair. So depending on the surgery and your practice, I would say, is it a surgery center? Is it a hospital? What are your surgeon's preferences? In my place where I practice, they would like me to do a femoral nerve block. Now, femoral nerve block does cause quadriceps weakness, but these patients go home with a knee brace and they're not allowed to walk anywhere for the next 24 hours. So it works out in these patients, but there are some surgeons who would say, just give me a saphenous nerve block. So there's data on both ACL repair being covered by femoral and saphenous. But SAMBA, which is Society of Ambulatory Anesthesia in the United States, has recently come up with guidelines in 2019 about the best block for these ACL repairs, apparently, is just local infiltration plus multimodal analgesia. So as the science evolves, the best block probably is just local infiltration for them with multimodal analgesia. And if your surgeon would like to leave a catheter, in that case, a saphenous catheter, because we want ambulation at some point. Femoral nerve is kind of falling off, but the current recommendation and strong recommendations from the society are to do a local infiltration with multimodal analgesia. So choose according to your practice area, choose according to your surgeon's preferences and your staff's skill at that point.
I've just read that paper, actually. It was quite interesting because we're almost doing ourselves out of work. We all love performing regional anesthesia, but I do think sometimes we have to look at the evidence and think, are we doing the correct thing for the patient by doing those nerve blocks? But yeah, it was an interesting paper to read. And of course, most of our nerve blocks, we also have to give our patients multimodal analgesia alongside. Making sure that we cover that post-operative. We give them a great nerve block, and then when that nerve block wears off and we're not there to look after them,
not great anymore.
Make sure we support them. We had one more question come through, and this is an interesting question and maybe a difficult one for us to answer. But it said, "I love the speech. The topic's great. I'm a pain doctor. How can I tell what ultrasound machine would be good enough for my work?" And that's a great question that I get asked a lot.
What was the last part? Say that again.
Which ultrasound machine would be good enough for an individual's work?
So the ultrasound machines, there's quite a few, as you know, and this is a seminar by Visonic. I am not partial to one or the other ultrasound. I think it eventually comes down to your visual liking, what kind of picture and what particular company you would like to choose. And there are handheld ultrasounds to larger ultrasounds, which can range from a few $1,000s to hundreds of thousands of dollars if you want to spend money on. So it all comes down to what your practice would like to use, or what nerves you like to find. Let's say you're finding, for pain medicine, if there's myalgia parasitic and you have to find lateral femoral cutaneous, or you're trying to find sural nerve, or you're trying to find superficial peroneal nerve, then I would invest, in a very good ultrasound with high frequency probes, versus if I'm just having to find a sciatic nerve, then I can just use a handheld ultrasound, which can be bought for a few $1,000s. So I think the question is difficult to answer, but the answer lies within you as to what really you like. You have to compare, contrast, and figure out what exactly you're going to be using. For chronic pain, I would say you'll be targeting a lot of smaller nerves. So investing in a high-end ultrasound would probably be the best thing to do, which I already have in my office.
Yeah, and I would agree. I mean, my normal advice to people is to trial those machines and don't skimp. Spend the maximum that you can afford to spend, because you will not be disappointed. This is a Visonics presentation. In my university, we have just purchased Visonics machines to use. My students are a younger generation. My students love the touch screen on the Visonic machine. As soon as I put the GE machine in front of them, the old Logic E, they're jabbing away at the screen, and I have to remind them it's not touch screen. I think that the new Visonics machine works very, very well. The images are very, very good. It's a very fast machine, so I'm very impressed by those machines. But as you say, there's a lot of machines on the market, and an individual has to trial those machines and see what's going to be best for them.
Yeah, I agree.
So I answered a couple of the questions that came through via the chat already. So one of them was about in-plane needling. And I know between you and I, you are very much an out-of-plane aficionado, and I'm very much an in-plane aficionado. So I took the liberty of answering the in-plane technique. I know you do in-plane techniques, but yeah, we both agree to disagree on the way we do this. And there was another one about TKA, total knee arthroplasty, which was answered. So I think that's all the questions that have come in. Nothing else has come in for now. So, Dr. Kalava, I would like to thank you very much for your excellent speech, presentation, teaching delivery this evening. I'd like to take the opportunity to thank Visonic for inviting us both to come for their Dandelion presentation this evening. And I'd like to thank everybody from around the world. I noted we had people from Argentina, Malaysia, Singapore. So, so a mix of people from there. So thank you very much for everybody, or to everybody, for joining us either this morning, the afternoon, or the evening, depending on where you were in the world. And I'm sure we'll pass it back over to Alex for the final word. Thank you.
Thank you so much once again for for the great sharing from Dr. Arun Kalava and the great moderating the webinar from Professor Mark Leonard. Thank you once again. Thank you so much.
Thank you, everybody, and good night.
So let's say goodbye. So for further information after the webinar, so all audiences can follow Visonic official account on those social medias like YouTube, LinkedIn, or Facebook. So we will also post these videos into those social medias, so everyone they can replay these videos. And if they have any other questions, so we will have transferred to the two professors who will be always helping. Thank you so much. Good evening. Bye-bye.